Okay, now for the question of hypertension, uh, we first made out that the patient has no drop, actually rise in blood pressure, and that's normal in a person. And that's no, that also, if his blood pressure be 210 and risen to 225, that would show he's essential hypertension. Now, if on the other hand his blood pressure fell, then his mechanism for control of blood pressure is disturbed by something. Now, I'll take pheochromocytoma as a good example. Pheochromocytoma, more than 50% of the patients do not have intermittent hypertension, they have persistent hypertension. But whether they have persistent hypertension or intermittent, they will have some tachycardia. That's the first point. And the second point is that because they are in a state of chronic vasoconstriction from the noradrenaline, they cannot further increase their adrenaline output. They're already maximally stimulated. So when they stand up, the only thing that can happen is their blood pressure will fall. And also, because they are chronically hypovolemic, their blood vessels are always, day and night, have been in vasoconstriction, meaning their vascular bed is restricted, is small, and they have no reserve to make the blood pressure go up when they stand. So 70% of patients with pheochromocytoma will have orthostatic hypotension, and that may be one of their symptoms. The same would be true of Cushing's disease. Now, Cushing's disease is very easy to diagnose. You can spend a lot of money doing a lot of tests, but the simple thing to do is, does the patient look like they have Cushing's disease? Now, we know what Cushing's disease looks like because we've all seen patients who are on steroids, and we know the round face, and we know the bruising they get, and the sore back, and all those things. Those are all signs. But the point about it is that there are a lot of fat people around who have round faces, so you need to know, what did they look like in a photograph 5 years ago? And if you see that their face is round 5 years ago, that is not Cushing disease. Cushing disease doesn't take long to develop abnormal features. If you have a patient on high-dose steroids, in a couple of months you can already notice the round face and the signs of hypercorticism. So just to look at the old photograph, 5 years or more, will say this is a chronic process, therefore it's not Cushing's, because Cushing's is a subacute process. And so that solves that problem, but you should suspect Cushing's if you see a person with a sore back, younger age group than the usual patient who has hypertension, and they have orthostatic hypotension because their blood volume is increased by the aldosterone, and the other features have come on very acutely, so that tells you there's Cushing disease. Polycystic disease of the kidney, you can feel the kidneys usually if the patient is not obese, and they have a hereditary situation, so mother or father, somebody had this, and the patients seldom are able to pass beyond age 40. After that, they die of uremia. And they have hematuria from time to time. They have a tendency to renal calculi. And so they are easy to recognize too. And now we come to the last condition that I'm interested in, and that is, does the patient have renal artery stenosis? There are two kinds of renal artery stenosis. One occurs in younger people, usually around age 30, and what they have is what's called dysplasia. And this is a long, not a single, not a single plaque like an atherosclerosis, but a diffuse thing, and it's bilateral, and they will present at a younger age, and if they're not diagnosed, then of course they may live a longer time, and you may find them, and they're quite old. It doesn't mean because they're old that they don't have it. It means if they're young and they have it, then that's dysplasia. Then the other kind is probably more common. That's where atheromatous plaque in one kidney, one renal artery, or in the other, or in both renal arteries, and this will make a bruit, which is typically has a short diastolic component to it. It's high-pitched, and it's heard just above the umbilicus and just near the midline, and you check on both sides. The patient should be lying flat, otherwise sitting up, the bruit will probably disappear. Well, I can hear it, but I don't think that'll pick it up. You might like to hear it. It's very soft. It depends. Do you hear it? Okay. Now, I'll show you how there's an orthostatic drop. It's 150/70, and I've been taking medication. $140. Over 55. So that shows you that I do not have essential hypertension. I have something in the other category, which could be one of those things that I listed. Okay, now the last thing is that I'm also on a beta blocker, and if I had a pheochromocytoma, I would have a tachycardia. So I'm just going to check my pulse. So my pulse is 48. So that rules out pheochromocytoma, and it tells me that probably I'm on a beta blocker, which is what I am, you see. I'm on a beta blocker. Okay. So there you got quite a lot of information. Now the next thing is you decide, has you had a myocardial infarction? Yes, I have had it. So, and the other thing is, am I in heart failure? No, I'm not in heart failure. And then the next thing is, what is the next test? And that is a captopril test for this. And then they measure the renin suppression of that. And then they operate after that. We're doing an angiogram. So that's the stage I'm at. Okay.